Thanks for joining us today, and thanks to the organizers for giving me the opportunity to talk today. What I want to focus on is quite specific. I want to review how clinicians can use MRI in the diagnosis of AFM. And I'm going to do that by reviewing the characteristic and non-characteristic imaging features that can be seen on MRI spine in these patients. So my presentation is primarily going to be images from MRIs, so I would encourage you to look at your screen, and if you're not in full screen mode, consider clicking the full screen mode so that you can see my images as best as you can. Okay. So I'm going to start by showing you the spectrum of abnormalities that can be seen in AFM on MRI. The radiological hallmark of the disease is T2 hyperintensity in the grey matter. This is typically longitudinally extensive and associated with edema, at least in the acute setting. So this slide shows you two typical cases of AFM. The cervical cord abnormality is obvious in both patients, as we can see in the top arrows here, but also extends down through the thoracic cord, again in both cases. Sometimes the swelling of the spinal cord can be quite substantial, and this is often the case in the cervical region. So as we can see here in the second image, the swelling of the cervical cord is actually effacing the CSF space that we usually see around the cord in this area. When we look closely at the sagittal images, we often see that the T2 hyperintensity and edema seen in AFM in the central cord are most obvious in the cervical and lumbar enlargements. These are, of course, the areas that contain the cell bodies for the motor neurons supplying the limbs. And it's interestingly also the location within the spinal cord where the ratio of the grey to white matter is greatest. So these are maybe some reasons why we see the most obvious abnormalities in these locations. However, it's always important to note that, like with anything in medicine, there will be cases where you see the full house of imaging characteristics, and then there will be cases which are not so typical or are a little bit trickier to interpret. So here are a couple of examples of cases where the imaging findings are not so clear-cut. The first image on this slide on the left, the quality of the imaging isn't that high. We can see swelling and central hyperintensity of the cervical cord, but it's not as clear-cut as in the prior images I showed you. The reasons for variation in the quality of the imaging are quite diverse. Obviously, we're often dealing with young children who need to be sedated for the MRIs. Movement artifact can be a factor, and also just the strength of the MRI machine. So 1.5 Tesla images are generally not as good as 3 Tesla images. In the middle image here, the swelling of the cord is actually quite well seen, but however, the central T2 hyperintensity isn't so obvious. And in the third image, the imaging quality is actually quite good here, and the central hyperintensity is apparent in the cord, but it's quite mild and there's not a lot of edema. So interestingly, there's a definite disconnect in the acute phase of AFM between the severity of the clinical syndrome and the severity of the MRI abnormalities. So it's not uncommon to see a patient with the whole spinal cord involved on imaging, but who clinically only has weakness of one limb. So at present, we're not quite sure why that is, and it's certainly an area that we're interested in looking at more in the future in research studies. So the next images we'll look at are the axial images that can be seen in AFM. The axial slices are really useful in distinguishing AFM from other spinal cord disorders. In the acute phase of AFM, often the entire grey matter appears to be involved and edematous, not just anterior horns. So this gives the butterfly kind of appearance that Kevin Meskar mentioned earlier. The degree of the grey matter hyperintensity and swelling can vary at different levels of the spinal cord. It's not always continuous. You'll also notice that in this series of images, I haven't included any slices from the thoracic cord. That's because often the quality of the images we get from the thoracic cord isn't as good as the lumbar and the cervical images. The diameter of the cord is smallest in the thoracic region, and there's many surrounding structures in the chest and abdomen. And they're some of the reasons why the images tend to be of lower quality in the thoracic cord. So sometimes it can be a little bit difficult to interpret thoracic images in AFM. Now, these are some more axial images which show that the classic butterfly pattern we've talked about is not always apparent in patients with AFM. It's because we see a spectrum of imaging and imaging abnormalities in the disease. The top row of images here were from 2 separate patients. Both of these studies were reported in the clinical setting as being normal in patients with acute limb weakness. But if we look back in hindsight, we look carefully in the central cord. In the first image here, there is abnormality in the grey matter, more prominent on the left of the cord than the right. And in the second image, the quality of the image isn't so good, but we can see that there's definitely central hyperintensity here, but it's not as clearly defined to the grey matter. This third image here, taken at C5, we can see that the abnormality is a little asymmetric. So the left anterior horn is clearly more involved than the right side. And in the example from C6 here, we can see there's a lot of edema in this patient. So while we see that the predominant abnormality is in the grey matter, it's clearly spilling into the surrounding white matter structures. Brainstem involvement occurs clinically in some patients with AFM, as we've already heard. This can manifest with bulbar weakness, facial weakness, and extraocular muscle weakness. And sometimes we see abnormalities in the brainstem on MRI. The motor nuclei do lie dorsally in the brainstem. So what we typically see in some cases is a hazy sort of T2 hyperintensity in the posterior medulla and the posterior pons. At the level of the cerebellar peduncles, this T2 hyperintensity can take on a kind of halo appearance around the fourth ventricle. This is a sign that Dr. Pardo has christened the scream sign, since it looks like the open mouth in Edvard Munch's famous painting. So the next question, as we move up the neural axis, is whether supratentorial abnormalities are evident on imaging in AFM. Based on our experience at Johns Hopkins and a detailed neuroimaging study published by a Japanese group, supratentorial imaging abnormalities are rare in AFM, and when they are present, they tend to be localized to the deep grey matter structures. In this patient, we can see that there is clearly bilateral thalamic T2 hyperintensity evident. This was even in the very acute setting within, I believe, 48 hours of neurological onset. Interestingly, the area of the thalamus that appears to be involved in this patient, I believe, is the ventral lateral nucleus of the thalamus, which of course is the motor relay center in the thalamus. And notably, some historical post-mortem studies of poliomyelitis patients did describe lesions in the deep grey matter in some patients, particularly in the motor relay areas. Next question is whether postgadolinium enhancement is seen in patients with AFM. And the answer depends on where you look and when you look. So parenchymal enhancement within the spinal cord itself is rarely present. If it is present, it tends to be just a little blush of enhancement associated with severe edema and breakdown of the blood-spinal cord barrier. However, enhancement is frequently seen in the nerve roots, primarily the ventral nerve roots, which are, of course, the motor nerve roots. Whether this ventral nerve root enhancement may be evident on an MRI depends a lot on the timing of the study. This does appear to be a slightly delayed phenomenon. In the Japanese study I mentioned earlier, they looked at 54 patients with enterovirus D68-associated AFM, and they identified that nerve root enhancement was rarely present in the first 72 hours after neurological onset of weakness, even though the grey matter lesions were clearly apparent in the cord at that stage. They did identify that this ventral nerve root enhancement was very frequent on any imaging taken at least 3 days after the onset of symptoms. And we have looked at this finding in our Hopkins cohort, and we've seen that this enhancement tends to persist for weeks or even months after the onset of symptoms, in some cases evident 6 months after. This is just the reference to the article I was mentioning about the very good detailed neuroimaging study. In the cervical spine, nerve root enhancement is not as easy to appreciate since the roots are not clustered together, but with a careful look, it can often be detected too, as demonstrated here. So the MRI findings tend to evolve in the weeks after onset of AFM. This is important to understand when assessing a patient who may have a delayed presentation. For example, they're misdiagnosed with something else first, and it's weeks before they get an actual MRI of their spine. So the edema settles down over this period of weeks, and the white matter involvement tends to resolve. Brainstem lesions also tend to resolve during this subacute time period. But importantly, what are left behind in the subacute and chronic phase are well-defined lesions in the anterior horns at some spinal levels. These well-defined anterior horn lesions are often asymmetric, and they may correlate with locations of residual weakness. For example, a patient with left arm weakness may have anterior horn T2 hyperintensity evident in the mid-cervical region on the left side, correlating to the motor supply of that limb. This particular correlation has been demonstrated in analyses by the Japanese group and by our own group in Hopkins. Interestingly, at some locations in the anterior horns where prominent residual lesions remain in the chronic phase, there may be corresponding T1 hypointensity as seen here. And this suggests that some of these lesions involved substantial tissue destruction. So at Hopkins, we've completed an imaging analysis looking at the subacute period in 20 patients with AFM with these findings. So we've noted that anterior horn cell T2 hyperintensity is evident in all of these patients. However, the number of spinal levels involved varies dramatically from one spinal level up to the whole spinal cord. There's associated T1 hypointensity of the anterior horn in around a quarter of cases, and lumbar ventral nerve root enhancement is frequent. So now I'm going to briefly run through some of the spinal cord disorders that can mimic AFM radiologically. And I'm going to focus on disorders which often affect the grey matter, which cause the most diagnostic confusion. MOG antibody-associated myelitis is possibly the most important differential diagnosis in my mind for AFM, since it is a very treatable disorder that responds well to steroid therapy and requires a certain approach to long-term management. It also frequently involves the grey matter when examined in a radiological sense, and it often causes hazy lesions which can be mistaken for AFM. In this case illustrated here, there are some clues that this is not AFM, such as these focal areas of cord expansion seen in the cervical cord, and the lesions being well circumscribed in the axial plane, at least at C2, with the grey matter more involved at C6. MOG antibody-associated myelitis often enhances post-contrast, which can be a clue to the diagnosis. Additionally, the brain should always be scanned when AFM is being considered, as findings such as these in MOG antibodies are an obvious abnormality that would not be seen in AFM, so it's a good sort of rule-out test. As a general rule, serum MOG and serum aquaporin 4 antibodies should be tested in all cases of AFM, since it is such an important differential diagnosis to detect and treat. Spontaneous spinal cord infarction or spinal cord stroke should also be considered in these patients. While this is actually thought to be uncommon in children, in our center we have seen that it's frequently misdiagnosed as transverse myelitis, and it's simply not recognized in many children. The MRI lesion in a stroke of the anterior spinal artery, such as in this case, often involves the grey matter, but does not tend to involve the posterior grey matter as much as AFM does. And this is why we get this owl's eye appearance even in the acute phase in some of these patients. Another overlooked pathology which may cause an acute cervical myelopathy with grey matter involvement in young children is the mechanical effect of a Chiari malformation. This occurs when there's herniation of the cerebellar tonsils through the foramen magnum, which may cause compression of the spinal cord or the vascular structures supplying the spinal cord at this level. In this patient here, the patient was initially misdiagnosed with AFM, but actually made a full recovery after this Chiari malformation was identified and surgically corrected. So to summarize, the green flags that suggest a diagnosis of AFM on an acute MRI study are a longitudinally extensive lesion, often involving the cervical cord. The abnormality tends to be hazy and predominantly in the grey matter, with minimal enhancement of the parenchyma, but with possible nerve root enhancement. By contrast, the red flags that can be considered pointing towards other differential diagnoses are focal discrete lesions of the cord, often sparing the cervical cord, any round or ovoid lesions, and particularly those that are white matter predominant. Lesions with focal enhancement or cavitation or cystic components also point towards another diagnosis. And finally, just in terms of the MRI brain, what one can expect to see in AFM is typically either a normal MRI brain or posterior hazy hyperintensity in the brainstem structures, rarely hyperintensity in deep gray matter structures. The red flags that definitely point towards another diagnosis are white matter lesions, cortical lesions, optic nerve lesions, and any areas of focal enhancement. So I'm going to pass over now to Dr. DiBiase, who's going to speak about AFM as an infectious disorder.